Hello, my name is Landon Trulove, and I am a Doctor of Nursing practice candidate in the Nurse Anesthesia program at the University of Arkansas for Medical Sciences in Little Rock. Today, I'll be giving a brief titled Fair Reimbursement for Qualified Anesthesia Providers. This presentation is to address the U.S. Senate Committee on Health, Education, Labor, and Pensions. Specifically, I will be addressing Committee Chair Senator Patty Murray and Ranking Member Senator Richard Burr, who both had integral parts in the No Surprises Act of 2021. First, I would like to thank the chairman and the ranking member of the committee for their efforts in passing the No Surprises Act, as it benefits Americans in protecting them from unnecessary practice of balance billing for otherwise covered so-called out-of-network services or surprise billing. As you know, Senators, the No Surprises Act came out of a very large federal COVID relief bill known as the Consolidated Appropriations Act of 2020. This was one of Congress's largest bills to date, costing upwards of $2.3 trillion, and it has a net benefit to my colleagues as CRNAs. Over 60,000 certified registered nurse anesthetists provide over 50 million anesthetics annually in the U.S., including 90% of rural anesthetics. CRNAs are Medicare Part B providers and since 1989 have billed Medicare directly for 100% of the physician fee schedule amount for services. Historically, CRNAs have been unfairly treated by insurers and seen as out-of-network by many private coverage policies. Patients then unfairly have been given the impression that CRNAs had snuck in services to bill them for services not covered by their insurance already, when in reality, the services were the same as the ones provided to you by an in-network provider with a different relationship with insurers. This commonly occurs for patients receiving labor anesthesia or during an anesthetic given during emergency surgeries. The rules in the No Surprises Act for an Independent Dispute Resolution, or IDR, don't appear to define what constitutes health insurers' good faith efforts to negotiate with providers. Without such protections in place, already powerful insurers gain even more leverage in the negotiation process with providers, including CRNAs. This ultimately deters competition and does not align with the intent of the No Surprises Act. I request that the agency add a provision that further defines good faith efforts for insurers and health plans in order to ensure that they negotiate in good faith with providers regarding the reimbursement required for each procedure. There also needs to be punitive measures in place for insurers that fail to demonstrate good faith during these negotiations. There's language in the Act discussing how providers will be penalized, but nothing about how insurers will be incentivized if they, for instance, fail to even respond to the provider's negotiation request in a timely manner. I would request that the agency add a provision that further defines good faith efforts for insurers and health plans in order to ensure that they negotiate in good faith with providers regarding reimbursement for services being included in their networks, and also add punitive measures for insurers that fail to demonstrate good faith during these types of negotiations. There also needs to be fair assessment in the IDR process that delineates compensation based on intervention cost and provider experience level, but not penalization for the type of licensure the provider has. It has been our experience already that CRNAs have been unfairly barred from compensation by insurers in regards to their licensure. I also would request that the IDR process would take into account the provider's full level of experience when considering compensation. A physician anesthesiologist and a nurse anesthesiologist with the same years of experience should be considered to receive the same compensation for placing the same type of epidural in the same patient. There has already been language changed on the provider side to define how providers cannot use billing practices to constitute a price offer during IDR negotiations. While fair in this regard, there is no measure in place to keep insurers from arbitrarily naming their price on what they might compensate the provider with. Being the #1 nation in the world for medical spending, we desperately need reforms that point towards decreasing medical costs. This policy change will improve the competition for providers administering anesthesia care across the country, therefore driving down consumer costs. The consequences of not pursuing action on these revisions could mean a further shortage of anesthesia providers and decreased access to care in areas that already suffer from surgical specialty shortages. As I've already stated, CRNAs provide 90% of rural anesthesia care. And as stated before, the only cost of amending this policy would be to insurers who are already unfairly manipulating their reimbursement practices that hurt the healthcare industry and the consumer. Insurers that aren't doing practices such as these would really not be affected by these changes. The benefits of amending this policy would be a healthcare workforce that can be equipped to fight fairly for a wage our economy can already support. In essence, what I'm asking is just to give David his sling and stone and not force him to fight Goliath empty-handed. Nurses of all practice levels have been through some of the most trying times in their career over the past several years of the pandemic. This policy revision would help to foster an encouraging and improved relationships with everyone involved in healthcare delivery, both from the provider all the way to the payer. And here you can see my references for the images that I used throughout the presentation. Thank you for your time, Senators, and I would appreciate your feedback on this issue.